Good afternoon, everyone. My name is Keisha Blain, and I'm currently an associate professor of history at the University of Pittsburgh and a fellow here at the Carr Center for Human Rights Policy. Welcome to the Social Justice Leaders Series. This is a webinar series which I started last semester, and this is just a great opportunity to bring to campus, at least virtually, social justice leaders who are working at the local, national, and international level. The series highlights the work of leaders of color in particular who are actively challenging racism and advancing human rights. I'm thrilled to be here today with Dr. Uche Blackstock. I will share a little bit about Dr. Blackstock with you all, but I have a feeling that most of you already know who she is. She's a thought leader and a sought after speaker on bias and racism in healthcare. She's the founder and CEO of Advancing Health Equity, which partners with healthcare organizations to eradicate racial health inequities through keynote talks, trainings, and consulting services. In 2019, Dr. Blackstock was recognized by Forbes magazine as one of 10 diversity and inclusion trailblazers you need to get familiar with. In 2020, she was one of 31 inaugural leaders awarded an unrestricted grant for her advocacy work from the Black Voices for Black Justice Fund. You probably have encountered her writing, which has been featured in the Chicago Tribune, Scientific American, the Washington Post, and Stat News for the Boston Globe. Since June 2020, she has been a Yahoo News medical contributor and appears regularly on cable and broadcast news programming to amplify the message around racial health inequities. And I'll just add that she recently became a contributor for MSNBC. She's a former associate professor in the Department of Emergency Medicine and former faculty director for recruitment, retention, and inclusion in the Office of Diversity Affairs at NYU School of Medicine. She left her faculty position at NYU School of Medicine in December 2019 after almost 10 years to focus on advancing health equity. And we will talk about her journey today. And last but certainly not least, Dr. Blackstock received both her undergraduate and medical degrees from Harvard University. So in many ways, she's returning home, virtually at least, for this conversation. So thank you so much for joining me today. It's really wonderful. I know we've connected on social media, but it's great that we'll have an opportunity to at least have a dialogue today. Let's start from the beginning, if you don't mind. Tell us more about your background, what led you to become a doctor, who or what inspired you?
Well, thank you so much, Dr. Blain, for having me and everyone else who's watching right now. So I'm originally from Brooklyn, New York, like you're familiar with Brooklyn as well, Dr. Blain, and I'm actually here right now, but I am a second generation physician, which is something that is, I think, a very unique and rare for a Black person in this country to be able to say. My mother was the original Dr. Blackstock, and she grew up about 15 minutes from where I am here in Brooklyn, New York, under very different circumstances. Born to a single mother, she had 5 siblings, raised on public assistance, really had to overcome just incredible amount of structural barriers to even get to college. She was the first person in her family to go to college, and she applied and was accepted to Brooklyn College. And there she actually had a professor who really saw her potential and her drive, and he encouraged her chemistry professor, to apply to medical school. It was something that she had never thought about before. She had never met any doctors that looked like her. And she ended up applying to medical school and was accepted to all of her medical schools and matriculated at Harvard Medical School. And of course, going there was a culture shock for her. She made it through. But what I admire the most about my mother is that after medical school, she came back to New York City, came back to Brooklyn, and practiced here in the same community that she grew up in for many, many years until her death at the age of 47 from leukemia, from acute myelogenous leukemia. So even though she had a short life, she had a tremendous impact on both my twin sister, who's also a physician, and me as well.
Yeah, and your career has been centered on health equity, especially bias and racism in healthcare. When did this particular path of balancing both advocacy and medicine start to take shape for you? Did you envision this as a goal in med school or after years of practicing as a doctor and in academia?
It's always been there because my parents, in both their professional and personal lives, really emphasized the importance of social justice. They would take us, we went to rallies at the UN regarding, South Africa. We went to rallies here in Brooklyn, New York, around, racist killings of young Black men. And so we've always sort of been out there. But what I think is interesting is sort of bringing that advocacy to medicine, which traditionally it's been difficult to do, just because it's a very traditional conservative discipline. But what I realized is that my mother was an advocate for her community and returning back to her community and working on behalf of her community, serving community members. She was very focused on improving community health and preventive health care in terms of sponsoring health fairs and working with local Black physician organizations in Brooklyn to target really the health of our communities. And so I feel like, that was always there for me. And I finally saw the opportunity when I was in academics, because what I actually saw within academics is that often our institutions, right, these academic institutions themselves have climates and culture that are not equitable, that actually are embedded with the isms, with racism and sexism. And I actually experienced that myself, but I also saw that my patients were coming in to the ER with what we saw were the downstream outcomes of systemic racism. I saw that in terms of disease manifestations. Black women are more likely to die from breast cancer than white women, even when diagnosed at the same stage. We know that about the Black maternal mortality crisis. This was Black Maternal Health Week, and we know that we often see these disparities. I like to call them inequities, even despite educational attainment of the mother, right? So we're seeing these health inequities even despite controlling for socioeconomic status. And I also think about Dr. Susan Moore, who is the Black family physician in Indiana, who had the video on Facebook talking about how she felt she was mistreated as she was hospitalized for COVID-19. But I think about her because I think that's a perfect example of how no amount of education you're even within your own field, that is not protective, that does not shield you from racism.
Yeah, and it's, as someone in academia, and I know that you experience this, there is so much, I think, resistance to the idea of leaving. It's somewhat odd to me, because I think everyone who's in academia will agree with everything you just said. We understand how these are spaces that are sometimes, quite frankly, violent spaces that uphold white supremacy, spaces where professors certainly experience racism, sexism, homophobia, just to name a few, and students experience this as well. And you took, I think, a very important step. Some would say it's a leap of faith, but an important one in 2019, when you decided to leave academia and to establish the organization Advancing Health Equity. Can you talk about that process? I imagine it was
Sure.
a difficult process. And then tell us more about the organization too.
Absolutely. And I would say that it was a process that I would have never imagined I would take earlier on in my career. Even 5 years prior, if someone said, Uche, you leave academic medicine. When I left, I was an associate professor. But what was also very clear to me was that there was tremendous amount of work that needed to be done. And I felt like I couldn't have that impact working from inside of an institution. I mean, and you mentioned this, often, these institutions, they were built to historically exclude us. And so it felt very much like an uphill battle. I will say that, I know my presence there was very important, especially for our students and trainees, to actually see people who look like them, one, but also we were more likely to mentor them. We're more likely to sponsor to them and provide them with support. And of course, not really receive any sort of recognition for that, in return. So carry, obviously that extra load. But it was really just sort of a series of events. I also felt very stifled. I feel like sometimes when you're part of an institution, you really can't use your voice the way that you want to, because it may not align with that institution's values or priorities. And it's interesting, I remember when I started my organization, Advancing Health Equity, because I really saw within my diversity role within the medical school that I needed to work with healthcare organizations, because they were not functioning in a way that would enable every patient that came into their ER, into their clinic, provide them with equitable care. And there were so many things that many clinicians, physicians, healthcare professionals don't even learn in medical school or learn in their training at all. So about the history, right? The history of medical racism, of scientific racism, and even not even aware of current data, right? I think people like to think that, oh no, we are providing everyone with the best care possible. But the fact is that there are so many factors that are present both within the clinical environment and outside, as we know, housing, jobs, education, that influence the health of our patients. And that's something that many physicians don't know. And so I said, I need to get out there. I need to work with these organizations so they understand sort of holistically how they should be caring for Black patients and other patients of color. So I started my organization doing mostly trainings, and then shifted mostly into organizational assessments around racial equity culture, health equity culture, equity audits of their practices and policies. So even right now, I'm working with a medical school that shall go remain nameless, but I'm reviewing their medical education curriculum and their financial aid policies and their admission policies to see if they are equitable, right? Especially, given everything that's happened over the last year. I will say that healthcare organizations, like other organizations, are now willing to put in not just the effort, but the resources to do this work.
Yeah, I think that is, one might say the silver lining of this particular moment, especially since last spring, and of course with the uprisings in the spring and the summer. I think people are generally more open, certainly open to learning, as I have observed, just as a writer, as a historian, people asking more questions, and so it's and as you note, actually taking steps to utilize the kinds of services that you offer. And I want to encourage those who are listening to begin to post questions. We will try to get to as many questions as possible, but feel free to post questions periodically as we're speaking, and we look forward to addressing some of those. From your experience and research, what are the greatest challenges facing Black Americans today within the healthcare system? And I know that there are many, but if you could identify a few for us.
Well, I think the major problem is that so much of what influences, as I mentioned, the health of our communities is not just what happens within healthcare. I think that, we could ideally have a system where everyone had access to healthcare. So obviously we want to make sure, I personally think a single payer universal healthcare system is what we should have in this country. Everyone should have access to healthcare. And then also, we know that when Black people interface with the healthcare system, that they often encounter provider bias, and they're not listened to. We have copious amount of data that shows us they're not listened to, their complaints are minimized, and so we know that their care is compromised. But I think also understanding, so there's this idea of structural competence, that we really want to instill in healthcare providers that the understanding that what happens in the four walls of healthcare institutions is not the only thing that impacts their care. So we want them to think about how social and economic policies, how social hierarchies like systemic racism influence what we call the social determinants of health. And so, those are not just only access to healthcare, but access to gainful employment with sick leave and benefits. That's also access to a quality education, to safe neighborhoods, to green space, right? So we want people to understand that that requires investment in communities. And I think that healthcare institutions should always have, an office of engagement. They really should be centering the communities that they are caring for. And so it's not just about providing clinical care, but it's about connecting your patients with the resources that they need. So if they are having immigration issues, if they are having difficulty paying their rent, and we know that's been a problem because the pandemic has not just hit our communities health-wise, but also economic-wise in the last year. But and then even also thinking about, our healthcare institutions, are they ensuring that patients have broadband access? Because if people, we know at the height of the pandemic, weren't going into the ER, they were too scared to go to the hospital. And do they have access to broadband so that they can make their telehealth visits, or even do they have a smartphone that they can use? Like, these are the things that we need to care about, not just whether or not you wrote a prescription for high blood pressure medication.
Mm-hmm. As you were talking, I was thinking about some of my own experiences, and what is so clear is that a lot of this, certainly within Black communities in particular, people understand these challenges and try to come up with ways to respond. And what I thought about immediately as you were talking was, when I became pregnant a few years ago, first time. So many of my friends said, make sure you get a Black doctor. I remember thinking, okay, well, this is interesting because I already have an OBGYN, I have all these people I'm working with.
Right.
And they said, still make sure you have another person you can consult who looks like you. And over again, people kept saying this to me. And thankfully, I took the advice. And I would say that it really saved my life in many ways, because as I encountered challenges through the pregnancy, I realized I would receive one set of information or advice, and then I would contact this doctor, an amazing Black woman, and she would say, "Nope, hold up a minute. No, don't be so quick to do that. Let me take a look. Let me come and see." And it was just really wonderful to have someone. And they were just, it's actually unbelievable, the moments where she stepped in, and I thought, if I didn't have this person here, I could have been in some serious trouble. And so I don't know how many people recognize how prevalent this is, and the kinds of, certainly you brought up, when it comes to pregnancy, these statistics are horrifying as it pertains to Black women. And I don't know how many people recognize how scary it is and how much we often have to struggle to figure out on our own. And so the work that you're doing is so crucial in this regard. And I just thank you. I think,
Oh, no.
everyone listening. Yeah, go ahead. And
no, I wouldn't. No, I actually, when I was pregnant with my two children, both times, I was also very, very worried, just given the statistics. We know that across the United States, that Black women are 2 to 3 more times more likely to die of pregnancy-related complications. And in some states, like in New York, it's almost up to 10 in New York City, it's 10 times as high. And those rates, those mortality rates have not improved and sometimes worsened in some states over the last 20, 25 years. So that's the other concern, right? So, we are having improvements in technology and innovation and in patient care. So why are we still seeing these inequities, right? And it's comes down to the individual, but also the systemic. And so we have to really analyze these problems at every level, because they overlap. And the fact is that I think that for healthcare professionals, it's very hard for them to face that there's a chance that they could be treating patients differently.
Right.
But that's what the data shows. I mean,
Yeah.
that's a little bit of it as well. I mean, even there was a piece that came out by Dr. Rachel Hardiman, who's out in Minnesota,
Hmm.
but a piece that she published last fall that showed, it was an observational study that showed that Black babies, when they were cared for by Black pediatricians and
Hmm.
neonatologists, that they had a lower infant mortality rate. They were more likely to survive to their first birthday than white physicians. And so, in thinking about this, these conversations I have with organizations, thinking about why do you think this happens,
Right.
right? That is, these are babies,
Yeah.
right?
Yes.
These are babies, but to think that depending on who is caring for your baby, that could
Hmm.
influence whether your baby lives or dies
Wow.
is just, yeah,
Yeah.
it's overwhelming.
It is. It is. And it's, I think you mentioned this before, how it really shapes the lives of all people. I mean, we're talking about Black women here. It doesn't even matter one's socioeconomic background, right? And I talking in the friends I was talking to, were mostly folks who, like me, have PhDs, and who are fortunate to even have health insurance and have, access
Right.
to good resources. And yet we were still talking about the need to make sure that we were protecting ourselves, right, beyond what
Right.
was available to us. So it's just not everyone could have gone to consult another doctor, or not everyone had people, in their lives, or to even point that out and to warn them about the challenges ahead. So it's really, really difficult. And as we're talking, a couple questions were coming in, and one in particular I think is really connected to the topic that you explored with your sister. In fact, I believe you and your sister co-authored a piece, if my memory is correct, on medical mistrust that probably a few months ago, and you were talking about understanding the history of the understanding U.S. history in order to make sense of the medical mistrust that's currently within Black communities. And so someone is asking, quote, can you talk about the history of how hospitals in America were desegregated and how Black physicians were instrumental in achieving this milestone? So I guess it's a broad question about history, both the medical mistrust, but also some of the gains, some of the milestones in this case that this person has identified.
Yeah, I mean, I think actually a lot of the desegregation happened as a result of the Civil Rights Act, and we saw that after in the 1960s and late 1960s, early 1970s. But it's really interesting. There's so much history, and even the American Medical Association, which is the largest and oldest organization of physicians in the country, they actually had sort of a very big role in terms of segregation of care. They were involved, they actually commissioned the Flexner Report. Are you familiar with that, Dr. Blain? So they,
No,
they
could you tell us
commissioned,
more?
so they commissioned an education specialist named Abraham Flexner around the turn of the century to go around the country and assess medical schools, as well as assess sort of the rigor of these medical schools.
Mm-hmm.
And he did this entire assessment on basically all the medical schools in the country at the time. And it led to the closure of, I believe, all but one or two Black medical schools. And
Mm-hmm.
and that actually had a tremendous impact on the number of Black physicians. There was a study in the Journal of American Medical Association last year that showed if those medical schools had remained open, they would have educated between 25,000 and 35,000
Wow.
Black physicians. And I have to say, whenever I talk about that piece, I actually I cry. I cried at keynotes because
Yeah.
when you think about how many patients those
Wow.
physicians could have treated, like, I mean, it is 25 to 35,000 physicians who would
Mm.
probably treated, I mean, I can't even, hundreds of
Yeah.
thousands,
Yeah.
millions of patients, and how that compromised the care of Black people in this country. because we know that
Yeah.
care was segregated. We know that Black people were not allowed to seek care in certain hospitals. And that it was because of the Civil Rights Act that led to the integration of hospitals. But then we had the problem of, depending on where you lived, that influenced funding to that hospital, the quality of care. We have hospitals that are termed minority serving hospitals that are in our communities that have been shown in the research to have fewer resources, lower quality care, fewer specialists, right? And so even if we do have these healthcare institutions in our communities, they are not offering the quality of care that are the same as in white neighborhoods. And what's interesting is that we even see that now today, during the pandemic, we saw actually here in New York City that depending on what hospital you went to, that influenced whether or not you survived your hospital stay with COVID. And we found that people who went to the private hospitals in Manhattan were more likely to survive than those who went to smaller community public hospitals in Brooklyn and Queens in the outer boroughs.
Yeah, and as you brought up COVID, let's talk about COVID-19 and the ongoing challenges. I know that you have been on the front lines, and in fact, I think over the last year, I've seen you, tweet about some of the experiences, some of your experiences, but also some of the things that you have witnessed. Can you talk about the impact of the pandemic on your work and your advocacy? And also, how has COVID-19 shifted or perhaps reaffirmed your professional goals?
Mm. I just got goosebumps when you asked that question because, it's interesting. I'd made this transition from academic medicine, and I was working predominantly, in the ER. When I left NYU to focus on my organization, I still was doing clinical work. So I was working in urgent care. So it was a less acute setting, and I thought actually it was going to be much less intense. But then the pandemic hit in March, and it was interesting because literally within a week of the pandemic hitting, I turned to our staff who are mostly of color, and I said, do you notice that everyone coming in looks like us now? Whereas before it was very racially diverse, socioeconomically diverse. It was all Black and brown people, mostly essential workers, service workers, people who worked for the MTA, subway, bus workers coming in with COVID symptoms. And at that time, we didn't have enough testing supplies to test everyone. But I had literally saw in front of my own eyes this shift that was a harbinger for what was to come, right? And we didn't have any data yet. We didn't have any racial or ethnic demographic data yet. And so I saw this and I said, this is not good. But I remember even before that, looking at the patients in China who were most likely to do poorly if they were infected with coronavirus. And they were patients who had diabetes, who had high blood pressure, who had asthma. And I immediately thought, our communities are most burdened with those chronic diseases. We are going to be hit first. And so I said, I have to start writing about this. So I wrote a piece that ended up in Scientific American about why I thought the pandemic was going to hit our communities the hardest. And then I ended up being interviewed by by Slate as well about it. But, some of the reasons why we, what I've mentioned already, the fact that we are more likely to work, or I hate to say we are more likely, but that we're limited to working because of systemic racism in public facing jobs. We are more likely, because of housing discrimination, to live in overcrowded housing, right? So all of these, we essentially, systemic racism has placed us at risk for not only being infected with coronavirus, but also doing poorly because we are burdened with these chronic diseases, and we are more likely to live in neighborhoods where the healthcare institutions cannot adequately care for us. And so, we are more likely to receive worse care or not have a hospital with an intensive care unit or an ICU specialist, right? Someone who has the skills to care for someone who's severely ill.
Yeah, and I was thinking about this, and probably just even in the early months of the pandemic, talking to relatives who are still going to work.
Mm-hmm.
and feeling frustrated and saying, this, you really should not be leaving your home, and having them say to me, well, what do you expect me to do? I'm not a professor, like I can't
Right,
sit in front
right.
of my computer and teach my class. That's lovely for
Yes,
you, but I have to actually go in, and it's a painful reality, because the truth is, what are people supposed to do? They have to be able to pay their bills, right? And so they were still getting on the trains, they were still in these overcrowded spaces, and yet at the same time that they're going to work in order to sustain themselves, they're exposing themselves a greater, and putting themselves at greater risk of contracting the virus. So it's just like a never-ending cycle, and it's just, as you pointed out, the systemic racism. I think that's what COVID-19, I think has done for people, those who doubted, even the
right.
existence of systemic racism. The data made it quite clear what was happening, and everything you've just described. Yeah, go ahead.
Oh, no, I was just going to say that, when I left my academic position, and I have to say, I obviously I was privileged to be able to do that, right?
Right.
To leave this secure job and find another opportunity just because
Mm-hmm.
of my education and my training.
Mm-hmm.
But I also took a leap of faith in myself as well. But I will say that the pandemic and the brutal murders of George Floyd, Breonna Taylor,
Yeah.
Ahmaud Arbery just reaffirmed for me the need to do this work. And because the other thing that is very very interesting is that we know that racism in other social institutions, so in the
Mm-hmm.
criminal legal system, in policing,
Right.
also impacts how people feel about the healthcare institutions, and
Right.
whether or
Right.
not, and Dr. Rachel Hardman also is doing a lot of research around this as well, but how it impacts in communities where there are high rates of interaction between community members and the police, high rates of police
Mm-hmm.
brutality. Those community members are less likely to trust medical institutions, less likely to seek care. And so I always like to communicate to physicians and other healthcare professionals that we need to care about like what's happening, because physicians like to be apolitical, and like when you're caring for Black people, nothing is
Yeah.
apolitical. um,
Absolutely.
we have to be involved in advocacy around the criminal legal system, around mass incarceration, police brutality, because that impacts our patients in their communities, and their health as well.
Yeah, let's talk a bit more too about the medical mistrust. I think you certainly saw on social media, certainly conversations around the Tuskegee experiment in particular, especially as we were at a moment where we're leading up to the release of the vaccines, and and part of that, I think is directly tied to the mistrust, because of course, there is a history and people understand,
Right,
they know the history,
right.
so they're fearful. Um, but what steps, how do we move forward? What steps must members of the medical community take to effectively address this mistrust? And what steps can lawmakers take?
Yeah, I think it's going to take a lot of hard work and effort on the part of medical institutions. I think that the history is just so profound and so deep, and a lot of the history is not known to people who work within within medicine or healthcare. People don't know. There's certain occurrences like Tuskegee that people hear about a lot, right? But the fact is that medicine in this country actually started out being practiced by physicians who were slaveholders,
Yeah, right.
right?
Mm-hmm,
And who
mm-hmm.
perpetuated notions of biological inferiority
Right,
of of enslaved people, enslaved African people,
right.
right? And so these were the people who were revered, who were trusted. Even when you think about, for example, phrenology, it was debunked as junk science in Germany, but actually there were American physicians who brought those ideas right over to this country. Charles Caldwell, who founded University of Louisville Medical School, he actually, used phrenology and said that Black enslaved people had bumps on their head that that signified that they were tameable, and he used that to justify slavery. So I think it's really not even known within medicine how how racism essentially is embedded in the foundation of medicine, right? So
Right.
I think that any way to address medical mistrust, yeah, it's dealing with the history, it's dealing with ongoing discrimination, recognizing and acknowledging that it's still occurring, right? And I think also it's about centering our communities. So how can institutions show our communities that they're more they should be more trustworthy, right? And I think
Right.
it's about having community members on the board of hospitals. It's
That's
about
helpful. Yeah.
having them on advisory committees, hearing what their concerns are, putting resources, because that's the other thing. I feel like, a lot of federal policies, the New Deal, GI Bill
Hmm.
have led to significant amount, racial residential segregation, the racial
Right.
wealth gap. Our communities have been divested in. So it's all about putting resources back into our communities. And I think that I think healthcare organizations should be led by us, or people who have, who are putting our communities first.
Hmm.
Something has to change. So it's interesting. I've been thinking a lot over the last few days about, about policing and, about abolishing
Hmm.
policing.
Hmm.
But I've also thought, because everyone's, the system is just broken. But I also think the system is broken in healthcare as
Yeah.
well. And so thinking
Yeah.
about, like, what does abolition medicine look like? What does abolition
Right.
healthcare look like? Right? Because, um, yeah, yeah, yeah.
Yeah, there's so many parallels there. And in fact, this is something I was thinking about, and particularly last fall, because, at Pitt, we, over the summer,
I'm
several,
sorry. Can I say something? I'm sorry. I said
yes, go
slaveholder.
ahead. Yeah.
I said slaveholder. I meant enslaver. I apologize.
Oh, yes, no,
Okay.
thank you. And thank you for that history too, because even as I'm listening to you, I'm struck by how many aspects of this history um, I don't know, as a professional historian. I mean, I think there are moments that we focus on, but even as you were talking about earlier, the Flexner report, so powerful, and important to know, and how it shaped, really the current
Absolutely. Yeah.
circumstances. It's
Yeah.
actually
And,
shocking.
and I think it's so important for people to know this because, we're in this current situation not by mistake.
Right,
It, it,
right.
it, it was by design, and there was intentionality behind it, and
Yeah.
it's cost us the lives of Black people in this country.
Yeah. And, at Pitt, we were talking about, so we were talking about the need to have every single student at the university take a course in the history of anti-Black racism. And
Mm.
one of the things that we realized was that we could have students, pre-med students, go through the entire program and never take a class where they learn any of this history that we're talking about. And then now, you're confirming that they could also go to med school and not learn it
Oh
there
yeah,
either.
no, no.
So, I mean, I think part of responding to this, as you pointed out, is the resources, but it's also even just starting early to make sure that anyone who decides they want to pursue, they want to become a doctor, they want to work in the field of medicine, that they're taking courses where they understand how how communities have been affected, how marginalized communities have been affected by these policies that we're talking about, and that should be required. Whether it's mandatory courses
Absolutely.
that you take as an undergrad if you're pre-med, or courses you take in med school, but that needs to change, and it's clear that changing even just the way people are trained will make a difference in
Yeah, no,
how they treat their patients.
absolutely. And even for an example I have is that, I went to this great medical school, but I also did not learn about where the cells that we were using in our histology class, where those came from. So we
Yeah,
were using Henrietta
Henry
Lacks
Lacks.
cells,
Yeah.
and I knew they were HeLa cells, but we didn't get any background on where those cells were
Yeah.
from during medical school. I didn't find out until I was a practicing physician that
Mm.
that
Wow.
we were using her cells, right?
Yeah.
And the history behind it, right?
Yeah.
The lack of informed consent, the fact that this was a woman, um, who who came there for help with advanced cervical cancer to Hopkins, right? And that Hopkins, as well as other companies, have made millions, if not billions, of dollars off the discoveries and research made by her cells. Also, her family did not receive, and they didn't even know that this had happened, right? So just the betrayal on so many different levels, right? Yeah.
Yeah, it's really, really I mean it's so painful just as we're talking about it. And I suspect too, certainly I do believe that part of the exclusion has a lot to do with people not wanting to confront reality, not wanting to
It's
confront the
ugly.
truth.
It's
It's
ugly.
ugly. Absolutely. And so, the answer is, well, avoid, so you
Right.
don't actually explain the origins of the cells, and therefore um, you're able to move forward as if, someone's life hasn't been devastated, but also that their family members, their ancestors are not still being exploited, to this very day. Can you talk about the role of unconscious bias, which I think is important here, because oftentimes when we're having dialogues about these topics, some people will say, and you've alluded to this too, right? Individual doctors will say, no, I treat my patients equally. What are you talking about? I don't, I'm not even a racist person, and they immediately try to explain it away. But there is this thing that we talk about, and we talk about it because it's real, and that is unconscious bias. Can you talk about how the role it plays in the day-to-day treatment of Black patients and other patients of color, and more broadly, how this bias influences the medical profession, and how does this endanger the health of people of color in the United States?
Yeah, so it's interesting. I like to make sure that I discuss unconscious bias on a continuum or part of the same, I don't know, as structural racism, because I think what unconscious bias is, and the ideas that people have are basically what happens when you live in a society with these deep structural inequities, with racism, and in terms of seeing, certain images on the media, what you hear from your parents at home, what you're taught in school, all of those cultural ideas and associations are internalized. And so I think what we're asking people is to we need to actually put checks in place. And it's not just about self-reflection, but actually in medicine. So for example, there is an emergency department at an academic institution that shall remain nameless, but they noticed that Black patients were waiting 80 minutes longer than white and Latino patients to be admitted to the hospital. Okay, so yeah, so part of it was we did it implicit bias training, but we also had to make sure that we had structured processes in place. So for example, that they were going to receive a dashboard that showed waiting times for their patients. And they would get that as a reminder regularly, but also that they would have, there would be a check within the electronic medical record system, that a reminder that would come up saying, these patients have been waiting for 30 minutes, please make a decision about their disposition, right? But I think what that speaks to is just how ingrained these unconscious biases are. And they manifest in terms of how well we listen to people, how well we appreciate their pain, right? Even, for example, there's actually a study that came out of UVA School of Medicine in 2016, and they gave these mock cases to 400 medical students and residents. And the cases were exactly the same. The only difference was the race of the patient. And the authors also made up these false beliefs about Black people. So for example, they said Black people age more slowly, Black people, their skin is thicker, they feel pain less. And would you believe about 50% of those students and residents thought those false beliefs were probably or possibly or true. And they were more likely to recommend a lower dose of pain medication for the patient and assess the patient's pain as less, the Black patient, than the white patient, right? this is 2016, right? And so,
Hmm.
and I think this is what happens when we live with anti-Black racism, right? Where there's this empathy gap in terms of, I look at this person, I look at this person, and I don't see this person as in much pain as this white patient
Yeah.
here.
Yeah, no, in fact, it's so striking to me, the interconnections to to policing, and in fact what that you alluded to earlier, because you mentioned empathy, and I've thought about this often. I've thought about what goes through a police officer's mind when
I
they
know.
encounter someone who looks like me, and I know I'm not the only one who've had sort of odd experiences
Right.
where people make assumptions, and those assumptions are directly tied to what it is they think Black people are doing. So you see a Black person in a particular space, and I have had this, even just on a college campus. The assumption is that I don't belong in that space, and so I'm questioned, and I have to prove that I'm in fact a professor, because it's not registering
Right.
somehow to the person who's questioning me, and it all connects, as you say. I mean, when you're bombarded every day in a society, through the media, I mean, just really everywhere you turn, anti-Black racism is so embedded in the society, that when you have encounters with individuals, there is, the empathy isn't even there. And
Right.
I just thought about that, like, how could things have been different if the, police officer who encountered, Dante Wright, was thinking, oh gosh, we're dealing with a pandemic. And so, oh, tags are expired. Well, you probably just haven't even had a chance to
Right.
deal with
Right.
that. Like,
I
that's a different
know.
approach, as
I
opposed to
know.
like turning it
Yeah.
into the
Right.
situation.
Right. Right. Exactly.
Yeah.
No, yeah, no, I know. But I mean, the question is, often we're asked, like, how can you teach empathy?
Mm-hmm. Mm-hmm.
Right. I don't know what to say. I don't know
Yeah.
if empathy can be taught, but I know
Right.
what happens in a society that, that's embedded with anti-Black racism.
Right. Right. Exactly. And someone has asked a question. They wanted to know if you could talk about the kind of support that you have found most beneficial in your advocacy work, either at the personal
Hmm.
or the professional level. I think that would be interesting to hear about. Hopefully,
Oh,
you do have some examples. Hopefully, you've been
I
finding a
know.
lot of support.
Oh, actually, what's been really wonderful is finding other people in this space or in similar spaces that care very deeply about addressing racial health inequities,
Mm-hmm.
um, or doing DEI work in other industries. But I definitely have there are a collective of us who we actually partner on different projects. So, for example, if there is an organizational assessment that we need help with, we can just call on the other team. And what's been very clear to me, that in doing this type of work, that you cannot do it on your own for many
Right.
reasons. One, it will exhaust you emotionally, because I mean, this is hard work in terms of the subject
Mm-hmm.
material. And we want to be in this for the long run. And so working together, I think, is the ideal. And then also, I've been fortunate enough to have people around me that believe in me,
Mm-hmm.
oftentimes more than I believe in myself. And so I think it's important just to get those folks to rally around you. But like you, Dr. Blain, I'm juggling a lot. I have small children. I'm running this organization. I have the media work, and the media work also for me it's very important that as a Black woman physician, that I'm out there speaking about issues that affect our community, because I feel so often our voices are not heard and they're not centered. People are not used to seeing someone that looks like me as a
Mm-hmm.
doctor. Even though my childhood was very different, because of my mother, she would take me to all of the to her meetings and conferences with other Black physicians. And so I actually grew up thinking initially that the majority of physicians were Black,
Right.
and then come to find out that we're only 5% of all physicians. Um, so I think for many different reasons, it's important that, especially given the media work, that's one of the main reasons that I want to be out there.
Yeah. And actually, let's talk about The Johnson and Johnson vaccine.
Oh yeah. Mhm.
In fact, and I was sharing with this you with while I was sharing this with you earlier. Just and many people can attest that it has already been such a journey and so difficult for many of us, I think, to have access to the vaccine in the first place. And we were talking about the medical mistrust that so many people that ultimately block people from even wanting to get the vaccine.
Mhm.
And now this news, which just I think devastated so many people, especially those who took the vaccine recently, just being terrified. And I remember, and for myself, I mean, just and I've shared this with you already. I had taken the vaccine, and then just a few days later, ended up
Right.
hearing the news and feeling completely terrified. And one of the first things that I wanted to do, which I did do, was reach out to friends and colleagues, to doctors who look like me, to ask, what should I do? If anything, because I'm scared,
Right.
um, and I suspect there are people watching who might be in the same position, whether it is about Johnson and Johnson or any other vaccine that they might be thinking about and worried about. Could you share your thoughts on the vaccine and certainly perhaps your thoughts specifically on the Johnson and Johnson vaccine?
Sure. And I'll just say, obviously my perspective is shaped by, being a physician and then also my lived experience as a Black woman. So I
Mhm.
understand that my perspective may be different than others listening, but I often feel like my job is to make sure people have the information they need to make an informed decision. So regarding the vaccines, I trusted the process for the clinical trials. And the data that I saw for me was enough to make a decision to say that these vaccines are safe and effective. I think what we're seeing now is something that actually is expected, that when you go from giving the vaccine to tens of thousands of people in clinical trials to like over 70, to millions of people, almost 7 million people receive the Johnson and Johnson vaccine, we're going to see those very rare events, those extremely rare events. And I have to admit, I was also so crushed at the news, obviously thinking about people's health, but even more so thinking about what does this mean for public confidence in the vaccine. I want people to know that I think what this means is that the vaccine safety process is working well and as it should be, and that this pause is important also to educate physicians and healthcare professionals about what to look out for and what to see, because again, it's very rare. I mean, I was practicing for 16 years. I've never seen this before. I thought my patients may have had it. I've given them imaging
Right,
studies
right.
for it, but they haven't had it. So what I will say is that when I first heard that the Pfizer vaccine was approved, given all that I had seen in my own clinical practice, taking care of people with COVID, I became emotional. I cried. I cried because I did not want to continue to see that level of human suffering. It
Right,
was it was
right.
just it was just too much. So that combined with the data that we have, I still feel very confident in the vaccines. However, I think that for people who have concerns about the vaccine, that one conversation may not be enough. It's a lot to process, especially I think that you know, and anti-Black racism specifically has traumatized us. So we are asking
Hmm, hmm.
people who are traumatized to trust this vaccine,
Yeah,
trust what I'm giving you. That and by all appearances, it seemed to have been developed very quickly, right?
yeah.
I'm asking you to trust this. And so I'm very, very patient in terms of that process. And I've had a lot of my loved ones, I've had neighbors that I have engaged with about the vaccine who eventually decided to take the vaccine. And I have to say, I was so relieved. I didn't say you should do it. I just said, what do you need to know? What are your concerns?
Right.
But I think again, what we're seeing though in this rollout though is those inequities play out again. We're seeing the Kaiser Family Foundation, they have been keeping up with the racial and ethnic data on vaccine uptake,
Hmm.
and we're seeing that Black and Hispanic people are not receiving the vaccine um, per the share of their population in the country, but also we are overrepresented in terms of COVID cases and deaths, and not even that either. And so I always say
Yes.
that what equity looks like in the vaccine distribution process is that Black, Indigenous, Hispanic people, we should be overrepresented in who gets the vaccine.
Yeah.
It's because we are in terms of cases and deaths.
Yeah, and I mentioned access earlier. I mean, I was so surprised, and I took a while just to be able to get an appointment for my mom. And I assumed that it would be, given her age, I thought, okay, this, it should be really quick. And no, just signed up and waited, and then tried other, different pharmacies and kept checking. And it's odd, but someone said to me, you need to get up early in the morning, you need to check at like 3 a.m. or 4 a.m. I thought, are you serious? I mean, I was stalking websites
I believe
3 in the morning, just refreshing several
Right.
different sites until I finally was able to get an appointment for my mom. And it was still like almost an hour driving. I thought this doesn't make any sense. Like, what if,
No, I know.
what if we didn't have a car, to
Yes.
take her? So I just, it's really, really, as we were talking about access earlier, and just in the way that this has affected, particularly marginalized communities, it's, I think it's, I really, really hope that, fingers crossed, that, as we are hopefully moving out of this, sometimes, some days it's hard to tell, to be quite honest, but
I know.
But imagining that we're coming to the tail end of this pandemic, I certainly hope that we'll see some radical changes in the healthcare system.
Absolutely.
Yeah.
Like if this were to happen again, we'd want to make sure that we don't see the inequities. But what that requires, I think, are legislation, policies, like deep structural, radical change, so that we don't see these inequities again.
Yeah. And someone's asking, which I think is a helpful question, about recommendations, books that you would recommend that address health equity. And I would also throw in, if I hope I'm correct, that you did announce that you have a book coming out. Did I see that?
Oh,
so tell us about your book.
Not yet. We're working on the book proposal.
Oh, okay.
So actually, that's going to be it's a memoir. So of my experiences as a Black woman physician, but using my personal experiences to illuminate some of the larger structural issues of racism in medicine. So I will keep everyone posted. But I'm looking at my bookshelf here. Medical Apartheid by Harriet Washington.
Yes.
It's amazing. Killing the Black Body by Dorothy Roberts. So those are two, and those are two that I would recommend the most strongly. Yeah.
Wonderful. And so, as we wrap things up, can you share with us what gives you hope, as we look ahead? And I know so many challenges, especially this week. I know I'm asking about hope this week of all weeks.
Well, I look at my kids, and I hope for them for a better world, especially little Black boys. There's so much, I think, that as you alluded to, that we can learn from this moment, and thinking about reimagining what justice and liberation looks like. And so I think that there are a lot of really smart, wonderful people like you out there. I think we need to work together and keep pushing. Yeah.
Thank you so much. It's really been wonderful. And I have to say too, it's this is really, I think, a testament to the power of social media, because we've never met in person, but I ended up sort of meeting you on Twitter, which is really nice. And so it's great that we were able to connect, and we were able to connect that way because of your advocacy and the great work that you were doing. And I was like, oh, there's a Black woman doctor tweeting about experiences that, this is important, and so I was really thrilled to discover you and to follow you. So thank you for your work. And I know it's difficult, especially in this moment, but know that you have a lot of support. And I hope that we'll get a chance to meet when it's safe to do so, and hopefully collaborate in the future. Yeah, so thank you again. And thank you to everyone who listened in. Please do follow Dr. Blackstock if you're on Instagram. She's on Instagram. She's also on Twitter. Follow her work, go to her, to her website. And I think whatever you can do to support what she is doing, to support her organization, please reach out and make sure that you're doing your part in making it, I think, a bit easier for her as she moves forward in her advocacy work.